going to be talking about something a little bit more mundane, about how I treat castrate-resistant prostate cancer today. And it's an interesting area because one that I think many people in this room are very familiar with, and I was thinking, what can I really add? We all know the same data. We all know the same trials. We all read the New England Journal. We all participate in the trials. And I don't even really need to review them today because these are now common knowledge. But I thought I might editorialize a little bit about some of the things that I think are bad about the state of the art, because I think at times we congratulate ourselves a bit too much. If you really want to know the truth, in prostate cancer, for advanced disease, all of our effects to date are really quite modest. And we congratulate ourselves a great deal, but when I show patients the curves, they sort of say, is that it? They want more, and they deserve more. There are lots of approvals, and I think everyone knows, if we didn't have mitoxantrone, prednisone, and placebo, maybe we wouldn't have as many approvals as we have today. There are very few trials that are even in the process of evaluating the active agents against one another. First Anna will be the first head-to-head comparison. I think we're going to be finding out right around GU ASCO. I don't know if it'll be able to be publicly acknowledged at that time. I call it cabazitaxel versus the unvanquished docetaxel. And I think you know why I say that. So far, there are no practice-changing combination or sequential trials reported. And it seems like there should be. That'd be an area that we would be able to go for. And everybody loves mom apple pie and personalized medicine. Dean, I love personalized medicine. But so far, nothing is changing practice for clinicians in Peoria. It is in specialized centers beginning to change, but the vast majority of patients are treated in the community, and we need to be able to take our advances from the centers into the community so that everyone can benefit. There was even a Time magazine article about the distinction in treatments that might be done somewhere in the middle of the Midwest versus a major center. It's important. Geography matters internationally and nationally too. The cost of drugs is a huge ongoing concern. I think the way it was addressed by Dean was very eloquent. We need to be thinking about this in terms of the biology. And we are continuing to administer drugs pretty much to everyone without a sense of really being able to understand the biomarkers that might enable us to be a little smarter. Another editorial comment, I think treating asymptomatic patients, which I think is a bit in vogue right now, brings a special sense of responsibility. In asymptomatic patients, the effects of the drugs predominate. And A reports, which look pretty good on the surface, capture frequency, not duration of events. Chemotherapy, where the initial AE concept was put together, is administered episodically. But oral drugs, given continuously, have persistent effects. And a persistent grade 1 and grade 2 event is highly relevant in an otherwise asymptomatic patient. Just look up what grade 1 vomiting is. It means you vomit every day. Well, if you're vomiting every day from an oral drug, that's not a very good quality of life. Treatment decision making in the clinic, it actually starts to some extent with availability of the drug, and cost is a major issue. Some people are not able to afford the copays. We spend an enormous amount of time with our insurance companies, with our patients, trying to ensure that they're maximizing their benefits. Many of the patients that I treat, as many prostate cancer patients are elderly patients. Many of them don't have tremendous resources. Cost is a major issue. Clinical trials are great, and I try to enroll every patient I can in a clinical trial. But it so turns out that availability of clinical trials is often a very problematic issue based on a platelet count, a liver function, or something that just makes the confines of the clinical trial a bit too tight for us to be able to handle in the clinic. Performance status, age, comorbidities, of course, laboratory assessments, platelets, liver function, of course, symptomatic or not, if so, where and how much, response, resistance to prior therapies, tolerance, intolerance to prior therapies, burden of disease, high burdens, low burdens, very different. Location of disease, bone is a little bit different than liver. at least in my clinic. Pace of disease, rapid or slow. Some of the immunotherapies we use in prostate cancer are probably best utilized for slow pace, low burden disease as opposed to high burden, high pace disease. Systemic or focal progression, we have a lot of opportunity to use external beam radiation, SBRT perhaps, to be able to palliate our patients. And a lot of times we end up with systemic drugs and a focal progression, and we can continue the systemic drug if in fact we control the focal progression with some form of local therapy. The phenotype, just very simply, adenoanaplastic neuroendocrine. You know, Dean was very eloquent on the genetic and genomic changes that have occurred, and we're drilling down, but in prostate, and I'll just touch on the biomarker issue here in a moment, we're still not quite there. And patient preferences, not always part of the discussion at conferences like this, but patient preferences are critical. Which drug for which patient? I think that boils down to one of the essence questions. Biomarkers are in fact a great hope. The AR variants and mutants unequivocally important in my mind. I want to give a little shout out to the people from Hopkins. I know a couple of people from Hopkins here. I don't know how many there are, but you know, really applaud your activity on particularly the variants and being able to bring those into the clinic and being able to, I think, to help us point a way forward. We now have biomarker-driven trials that the FDA has actually endorsed, and we are making progress. The germline and somatic DNA repair, there are some people in the room who have made tremendous advances in terms of our understanding of DNA repair, and then sort of the shocking discovery that a huge percentage of our patients are going to have somatic alterations in the DNA repair pathways, but also the germline individuals, highly enriched in CRPC, 6% or higher. Goodness gracious, we never would have anticipated that. Newer methods of CTC analysis, Epic Sciences gets a bravo here. Immune signatures, still quite interesting in prostate cancers, provocative data that in my mind has not been followed up. One of the things we need to do, we need to turn our individual laboratories into industrial processes. That's happening, but we need to do it faster and more, because what occurs in a small lab, in a small institution or a big institution is not necessarily going to change the practice in Peoria. We need to create the industrial processes that are necessary to engineer the detection of biomarkers and to be able to create opportunities for our patients all across the globe. So far, we're pretty good at identifying poor prognosis with a pretty high degree of certainty, and we're trying to pick our winners. I'm not going to be talking a great deal about biomarkers, but I'm going to point out something that I don't think is pointed out often enough. They're tumor-focused biomarkers, and there's a huge amount of activity in the tumor-focused biomarkers, proteins, DNA, RNA, CTCs, you name it, all sorts of imaging. But we also forget at times about the host reaction to the tumor. And yes, this does include the immune system and all the manifestations of the immune system that we've touched on very briefly, but simple things, pain and performance status, alkaline phosphatase, predominantly derived from bone, albumin, technetium bone scans, which is stromal-based imaging, hematopoietic cell function, hemoglobin nucleated red cells, etc. And if we look at the updated Halaby nomogram for patients treated with docetaxel, what we see is a remarkable enrichment for host factors. Opioid analgesic use, if the patient is taking an opioid, that is of prognostic significance. The ECOG performance status, one of the most important, or Konosky, however you'd like to word it, but performance status matters, how the patient is affected. Albumin, that's synthesized in the liver, it's not synthesized in the tumor cell. Critical variable in terms of understanding prognosis. Hemoglobin, same thing. Alkaline phosphatase, the vast majority of these are derived from the bone, in some cases the liver. PSA, important, but not that important. One of the things that I think befuddles patients in particular is what I call the PSA to LDH transition. I could probably name it something else, but early in the disease, PSA is a wonderful marker. And in fact, if you don't have a prostate, the marker of PSA is just about perfect. We use it to guide therapies, salvage radiotherapy. PSA is of 0.07. We're moving into action. Without a prostate, PSA is just about perfect. But later in the disease, the reliability of PSA declines, and LDH and alkaline phosphatase emerge as more important. And the PSA to LDH transition escapes many doctors. When I talk to people and I ask, okay, what was that LDH? Can you tell me about it? And they quote me what the PSA was. And that's not really what we need to know. There's something about that old Warburg principle that I think links to LDH that I think is of enduring importance. In patients, you have to educate them. You really have to talk to patients. Here's something from the Alcemca trial. It's just a scatter plot looking at the correlation between the log of PSA, the log of ALP, and the log of LDH. On the left-hand side, you see the log of PSA and the log of LDH. And what you have trouble seeing there, and I'm not quite sure it didn't come through, so I thought it showed on my computer, is a correlation of about 0.15. In other words, the relationship between PSA and LDH is actually no relationship at all. The relationship between LDH and alk-phos is a little bit better, but nevertheless not so poor. So we've got to get in our mindset, we've got to get beyond the PSA marker, particularly in these patients with advanced disease. Assessing response and progression in the clinic today. We have our usual culprits. PSA is one, LDH is another, images and patient-reported outcomes. I don't think we can ignore any of the above. When we're evaluating our patients, we have to talk to them, we have to listen to them, have to understand how they're doing clinically, and look at their biochemical parameters, and look at their hematologic parameters, and look at their imaging. And only when you look at the entire picture can you begin to see all the parts of the elephant. Each drug has its own profile. I think at times we simplify a bit too much. CTCs look great with cabozantinib. When I looked at those CTC plots with cabozantinib, I just thought we had the cat's meow. Didn't turn out to be the case. PSAs look pretty bad with radium. Radium prolonged survival, cabozantinib didn't. Response and duration of response are very distinct. I enjoyed the swimmer's plots that Dean was showing, because waterfall plots of best responses, I think, are overplayed. It turns out that duration is far more important than depth of response for many of the patients that we treat. This is interesting. Presented at ESMO. I doubt if too many people saw it. It's just a little poster along the way. These are placebo patients who received 1 to 4 versus 5 to 6 injections. I think all of us know that duration of therapy is very important. Well, how about the duration of placebo? And here it is. Those are pretty dramatic differences. 6.1 months versus 15.8 for 1 to 4 placebo injections versus 5 to 6. That's a little bit of a surprise. Nevertheless, I think it's important. I'll touch on this more tomorrow, because then you might say, well, goodness gracious, well, radium probably doesn't do anything. Actually, what radium does is dramatically increases the number of patients who are able to get those 5 or 6 injections. When do we stop therapies? Stopping depends on the availability of alternatives. Docetaxel and repeat docetaxel was in vogue when docetaxel was the only choice. And by the way, geography still matters. When you go to a number of countries, recently for me in Botswana, what we have is a very different scenario, and they learn how to use their ketoconazole and their flutamide and bicalutamide very well. When abiraterone was first approved, 1 cycle of docetaxel was given, and then the patient would be prescribed abiraterone, because abiraterone could only be given post-docetaxel. So let's just give the patient 1 dose, by the way, a mini dose of docetaxel, and then put them on the drug we really wanted. When many drugs are available, which is where we are now, skipping from drug to drug, which I call switching too soon, or failure to switch, switching too late, are both common. It's quite interesting. I just saw a patient who had been through 5 different FDA-approved drugs. He now had a PSA of 0.8 and rising, and the question was what to do. Well, goodness gracious, it was a little tough to be able to handle this one. But it's okay. I started back at the beginning. I hadn't seen abiraterone in about 5 years, so I put him on that. Not advanced enough for a clinical trial. Progression. I mentioned focal versus systemic. That's important. And the new prostate cancer working group 3, submitted and hoped to be accepted in the JCO, no longer clinically benefiting, I think, is an important category. And we've tried to drill down on it, but it's disease progression, toxicities, quality of life. It's not always so easy, but no longer clinical benefiting is really important. The process of shared decision-making. I alluded to how patients make decisions. And a lot of times patients come to me, and I may be their 4th or 5th opinion. They're well-educated patients. They're just trying to get a handle on the situation. Some of them are doctor shopping. The guy who saw me as, consult number 8, I really said, what can I possibly do? He had already been to UCSF, Michigan, and New York, and ended up in Boston in my particular clinic. But, what can you do for those patients? But I think we owe it to our patients to communicate what we know and also what we do not know, and ask the question, is there additional testing to facilitate the decision at hand? Understanding the relevant data, clearly communicating the pros and cons of reasonable alternatives to our patients is part of the art of being a physician and very important. But you don't just have to understand the immediate decision, you have to understand the downstream consequences as well, particularly if future choices might be limited. Educate your patient. In the end, it's their decision. So where do we go from here? We're currently in this sequencing paradigm. We give drug A, then B, then C. This paradigm will not last much longer. We've got to get smarter at choosing the right drug for the right patient. But I do remind you, as somebody who trained at the NCI when Vince DeVita was there, and he educated us about MUM, about taking therapies with non-overlapping toxicities, distinct mechanisms of action, combining them together to cure what was before an incurable disease. And it did take 4 drugs to cure Hodgkin's disease. And I think we're going to have to come up with multiple drugs in combination to take the next big step. So the horizon looks pretty intriguing from here. Thank you very much. Pleasure to be here in Bay.